Mike. Thank you for the kind introduction and again for the invitation to participate in this great symposium. It is always a tough follow-up to after this wonderful discussion we just had, and very often when somebody talks about something as a nephrologist, I have one or two objections, but not because I know Richard very well, but I think I 100% agree with everything he said, and I think to me, from a hypertensive nephrology standpoint, the middle of the road to somewhere between 3.5 to 5.5 grams of salt divided by 2.5 of sodium is sort of, to me, is the ideal way to go. So let's get going. I would like to not make nephrologists out of you today, but I would really like to give you an idea of what I think as a nephrologist and non-nephrologist, in particular a cardiologist, needs to know. So first, every one of us knows that if your eGFR is in a stable patient less than 60, they have CKD, and this needs to be present for essentially 3 months. So one time is no time, and so you need to repeat it to make sure. Hospital eGFRs are incorrect very often because you're sick, you're not eating, you're not drinking, and you may have fever and other issues lowering your pressure. So basically, ideal in outpatient situation. What we now have is a recently much stricter second definition that you can have a eGFR of 90, but you have an albumin of 30, again present for more than 90 days, and you also have CKD, and we're not making the diagnosis of that. To me, what is a urine albumin creatinine ratio? We used to call it microalbumin screen, or what you do is all you need is about 15 or 20 cc's of urine. You submit it to the lab. As of January of this year, all labs supposed to have at the bottom this UACR. And why are we correcting it for creatinine? Because you're taking in furosemide and you're drinking very little. There's a huge volume difference of urine output, and it corrects for it. So urine albumin creatinine ratio is correct no matter how little or how much you drink or what diuretic you're on. Okay, so we also used to talk about micro and macroalbuminuria. We got rid of it. Why? Because micro isn't the small albumin. And also micro doesn't mean it is of very little importance. We now know that if you have consistent albuminuria, let's say of 50 or 60, and then the UACR, and I do a renal biopsy on you, and that's going to be published very shortly from University of Washington, you can see that there are abnormalities on the glomerulus by histology from the pathologist. So basically, we're becoming very much albumin-oriented. And also to tell you that if you look at this from a renal standpoint, when you measure eGFR, you measure renal function. It is an ml per minute. If you measure albumin, you measure renal damage. It has nothing to do with function. So it's like two sides of a coin. So if you don't do urine albumins on all of your patients, and I'm going to tell you which ones you should do it on, you're missing 60% of the early diagnosis of CKD, and therefore you won't address the issue. Because most people who develop CKD from an eGFR standpoint have actually albuminuria first. So there are 3 ways to make a diagnosis of CKD. You either have an eGFR less than 60, or you have albumin in the urine of 30 or more, or you got them all together. Okay, so that's the bottom line. Why is it so important to make a diagnosis of CKD? Because it is not just a concern that you will lose more renal function per year, but CKD by itself is a major cardiovascular risk factor because it is associated with a much higher incidence of CVAs and heart failure. And it's hard to compare it, but it may be as bad or worse than a very high LDL. Okay, and we can treat the LDL very well, but we don't have such a great medication to reduce, improve renal function. We can slow the progression, but we can't reduce renal function. So if you look at CKD in the US using the albumin and or eGFR as a guideline, we have 37 million Americans. This is an identical number to the number of diabetics. And it's 1 in 7. And if you ask patients, they know they're systolic, the diabetics know their A1C, very often they know their LDL, but nobody knows what the EGFR is. So I always tell the patients now, I said, look, if you're diabetic, for example, or you have multiple diseases, you need to know your numbers. As a diabetic, you know your A1C, your EGFR, your LDL, and you need your systolic blood pressure and your urine albumin. So you need to know the 5 numbers. And if I give you drugs for each 5 of them, now they're not complaining about taking 6 or 7 drugs because they know that each one of them needs to be addressed too. So if you look at the diabetics, they are the number one reason we have 15% of the adults, because we've got 37 million Americans with diabetes, and half of them almost have CKD. So that's the issue there. Quickly, if you turn 40, what happened to me a long time ago, so you lose 0.7 ml per year and maybe as much as 1 ml, but we're closer to 0.7. The problem with that EGFR formula, which was developed by the NIH, there was all people younger than 60 when they did this. They never really thought about the 70 and 80-year-olds. So right now, if you are 70 plus, about half of the people have an EGFR of less than 60, and we should not call that CKD. So if you see an 80-year-old with an EGFR of 55, you can call this normal for age, provided times 2, that you have a normal urine albumin. So don't call somebody no CKD at age 80 plus who has EGFR of 55, but they have albinuria. So it's very, very important. A diabetic with albinuria, and of course, the higher the albinuria, I'll show you that, the higher is your loss of renal function normally, because albinuria to some degree is nephrotoxic. I'll explain that. We'll lose 2 to 5 ml per year, and that's on an ACE inhibitor or an ARB. So this is why we have that many patients ending up on dialysis. Okay, so now in nephrology and also in diabetology, we actually sort of rearranging our specialties. So now we talk at many conferences nationally at the cardiorenal metabolic patient. That's a patient who has diabetes plus minus obesity plus minus some degree of reduced renal function or CKD. So these are the patients you get paid for, and you should be doing not just an EGFR, which is done routinely because it's by law. If you do a creatinine, you have to be calculating it, but you should do it at anybody who has metabolic syndrome, prediabetes, hypertension. All hypertensive need to have both tests once a year. Anybody with underlying cardiovascular disease, heart failure, and if your BMI is 30 and you have no other diseases yet because you're 19, you have a very high risk of developing albinuria and subsequently also hypertension. So basically, these are the individuals who should be screened for. So one more time, the albumin less than 30 is normal, over 30 is abnormal. Again, it needs to be confirmed and needs to be present for at least 30 days. The albinuria by itself, one of Dr. Bacchus is one of my favorite nephrologists in the United States because he usually is always right what he predicts. And he calls albinuria the renal CRP. He said the C-reactive protein of the kidney is albinuria. If you have albinuria, you have system-wide endothelial dysfunction. So, matter of fact, if you check all the males who develop erectile dysfunction, a large proportion of them has endothelial dysfunction, and they also have albinuria. So this is very important to think of albinuria. You can look at heart failure data. With everything being equal, if you have albinuria of 200, 300 milligrams, the UCR, you have double the risk of heart failure. And the outcome data from the heart failure world, that if the cardiologist improves albinuria, because they improve, of course, cardiac output and indirectly kidney function, but they also improve albinuria, that is a very good prognostic sign. So the lower the albinuria gets with the treatment of heart failure, it is a very good prognosis. So what are the false positives? Well, if your sugar is over 300, you're hyperfiltrating, that gives you a false positive. Fever, 101, 102, and prior exercise, well, not just walking, but maybe running 4 or 5 miles, a UTI in a menstrual period. So you need to be aware of false positives. Now, this is sort of like overwhelming everybody, and we call this the heat map because we got all these red boxes in there. But I just want you, the way I look at this heat map is, it shows me two things. Number one, the lower one's eGFR is, if you look at this here, the lower the eGFR is, the faster you lose renal function. So what does the deep red mean? That you may lose as much as 4 to 5 ml per year. So the lighter one, the orangey type, is about maybe 3 ml. The yellow one is about 2 ml. And green is less than 1 or 1 ml. So basically, to me, you can show a patient that the more albuminuria you have, even with decent renal function, at a higher risk of loss per year you are. And the same is true for the eGFR. So this is one table which gives you sort of the risk factors where your patient is, and that should guide you how aggressive the treatment should be. Okay. So here is a study from two, fairly good institutions. One is the UCLA system and the Providence system from Seattle. So they looked at patients with a diagnosis of CKD, eGFRs were less than 60, and they had pre-diabetes, diabetes, or hypertension, and they found over 600,000 of them. The mean eGFR is 53, and look who had a UACR tested. I can't believe it. So fewer than 1 out of 10 who had CKD never had a urine albumin creatinine ratio. And even the ones who were tested, the few, only 1 out of 5 received an ACE inhibitor A or B. And my favorite complaint is that if you think you can give somebody 50 of losartan or 20 of lisinopril or maybe 150 of irbesartan, yet you're doing anything for albuminuria, it's diddle squat. You may as well spit in the ocean. From a kidney standpoint, you will not lower albuminuria, you will not preserve renal function until you get into the 80 to 90 to 100% of the dose. So 30 milligram to 40 of lisinopril. 100 of losartan or 300. There's a study done on 100 of irbesartan for albuminuria. It did absolutely nothing. You went to 300 milligrams, you had a 35% reduction of albuminuria. Okay, so you really need to go to the full doses. But look at this. The people didn't receive an ACE inhibitor A or B who had albuminuria, but they sure got 33% got an NSAID or a proton pump inhibitor. So we're giving them freely, potentially nephrotoxic drugs, but we're not giving them the drugs they need. And this is this study is from it's 2020, so not 29. So it's 2 years old. It's a typo. Okay. So the main cause of CKD for you and me is hyperglycemia, which means diabetes, uncontrolled, and the pressure is above 140. So actually, if you walk around with 135, you will have a very hard time to see this as a cause of new onset of CKD. And I'll talk particularly about obesity. If you have albuminuria and you smoke, you can double it, and if you stop it, you can reduce it by 50%. So smoking causing endothelial dysfunction is strongly related with the potential worsening of albuminuria. So looking now just quickly at diabetes, to show you the comorbidities, 85% of diabetics have hypertension, 83% have obesity, and over half have multiple parallel abnormalities. And here are some nice numbers. If you reduce the systolic, which is to less than 150 over 15 years, you have a 15% lower complication from a nephrology standpoint. I like the second number too, that if you're above 140, it seems to be very important from a nephrology standpoint. A 10 millimeter reduction of systolic lowers albuminuria risk by 15%. That's new onset, and the risk of developing new onset CKD. So this is just to give you an idea why we chose the difference between new onset and development of CKD. Oh, this is a little slow here, but that's all right. So I thought I'll put together on one slide what do I think are the mechanisms behind. So when you say, okay, what causes the onset and the progression that your eGFR gets below 40 and or you develop albuminuria. And I think hyperglycemia that is number one. There are other products which are glycolated. We call them HEEs, and insulin resistance, and then obesity. And I'll give you 3 slides on obesity. Importantly, also are conditions which make you hyperfiltrate. What does that mean? That means your eGFR, instead of being 90 or 100, is 120. So in the early phases of diabetes, you can have hyperfiltration. And if you're obese enough, you also need to excrete the salt and water, and therefore you're also hyperfiltrating. And so in obesity, very often you have, particularly early on, a hyperfiltration. And of course, if your systolic blood pressure is higher, that transmits to the glomerulus. And what that also leads to activation of the renal and angiotensin system. And then, of course, we talked about earlier today about inflammation. So chronic inflammation is bad to the kidney too, because it's endothelial dysfunction. It can cause albuminuria. And then you have activation of cytokines, and your C-reactive protein goes up, and you also have oxidative stress with reactive oxygen species becoming more common. So the cardiovascular risks in CKD are way underappreciated. Let's just say I see a patient, the eGFR is 30, and the patient is referred to me, and of course the patient knows seeing a nephrologist. Their main concern is, oh, doc, what can we do to prevent me from going on dialysis? And I think that's not my first thought. My thought is you know what, your chances of dying before dialysis is like 70%, and your chance of going on dialysis is 4%. So of course you're not going to tell that to the patient. But basically what that shows you is that you need to be super aggressive. Behave like a cardiologist. I mean, you got to get their pressure down to less than 130. You got to get the LDL, which my favorite, by the way, is, partly because of my still reading all the European literature and going to European meeting. To me, an LDL has got to be below 50 if you have a cardiometabolic syndrome, diabetes, or hypertension, or CKD, and you get your weight down if you can. And we heard about sleep apnea earlier today. So basically, you try to do everything correct. So you try to modify anything which from a cardiovascular standpoint is a major negative. And this is studies actually from the Kaiser Foundation from looking at over 1 million people. And what it shows you is, look at the eGFR, and these are the events per 100 patient years. So that means it's either 10 patients for 10 years followed or 100 patients for 1 year. So basically they looked, and if you go below an eGFR of 45, the middle column, you have already 11 times greater cardiovascular events, which would be either MIs, CVAs, and very importantly, heart failure. So matter of fact, if your eGFR goes from 70 to less than 45, irrespective of what caused that, basically you either, whatever it is the cause, and you didn't have heart failure, you just doubled your risk. So going below an eGFR of 45 doubles your heart failure risk because you're excreting less salt, you're excreting less water, and you're stimulating the RAS system, aldosterone, the catecholamines go up, sympathetic tone goes up. So that basically shows you the very high incidence of cardiovascular disease which you have with each of our particularly below 45. So don't get scared and say, oh my God, my eGFR is 52. I think the real divider is below 45. And so I came up with a list because I thought we have these nice traditional risk factors we learned for the cardiologists, hyperlipidemia, obesity, and hypertension, and the LDL, and smoking. So we have this long list of clearly established traditional risk factors. So I thought, let's call these guys non-traditional, because these are the renal causes for accelerated arteriosclerosis or cardiovascular event, which is oxidative stress. And look at this, inflammation. This is, again, you measure C-reactive protein, and the glomerulus is nothing but a sophisticated endothelial lining. I mean, it's a triple layer. It got endothelium, a basement membrane, and you got an epithelium, which is the podocytes. So it's a 3-layer constellation. And if the endothelium gets diseased, and the albumin then has a much greater chance going through it, although the podocyte is the critical barrier. So again, you have the endothelial dysfunction, you destroy more nitric oxide because you produce compounds ADMA, which does it. And importantly, you got the activation of the renin-angiotensin systems. Your renin goes up, your angiotensin 2 goes up, and your aldosterone goes up. And aldosterone, by the way, is very pro-inflammatory if it's overactive. So the drugs we use, like mineralocorticoid antagonists, the MRAs in nephrology now, and particularly for years in cardiology, are clearly anti-inflammatory and therefore quite helpful for patients who have heart failure. So this is the long list of the non-traditional. So now let's talk about obesity. As I mentioned earlier, we're at 42% in the US with a BMI of 42, and I heard the number earlier from Dr. Pecky. You said that we're going to be at 50% by the year 2030. And so what you need to know is that the average BMI of all diabetics in the United States, the type 2s, is 31. Okay? This is just unbelievable that you look at all the studies. However, I want you to know that obesity by itself, without being hypertensive or having prediabetes or diabetes, has a higher risk of albuminuria. So if somebody's BMI is over 30, you ought to really test them for urine albumin creatinine ratio 2, and that should be a wake-up call to A, lose weight, and B, you got to start an ACE inhibitor or A or B for the albuminuria, because you have endothelial dysfunction, and so you want to potentially make it normal or get it down to the lowest denominator. So basically, 85% of people with a BMI of 30 or higher have hypertension, and the reason is higher salt and food intake, but also there is a linear relationship. It's beautiful between BMI and aldosterone level. Everybody just thinks aldosterone is produced from angiotensin 2 on the adrenal gland, but the fat cells, the adipocytes, they have a releasing factor which actually stimulates the production of aldosterone in the adrenal cortex. So there's a linear relationship. If somebody's BMI is 35 and they do a aldosterone level, it's high, normal, or slightly elevated. And it goes up the more higher the BMI is, and the lower, and you lower it, it comes down. So there is a clear-cut relationship between, the same is true for HCRP. The C-reactive protein number one cause is obesity. Okay, and you lower the weight, this C-reactive protein goes down. So obesity is a chronic inflammatory state. So that's why people don't feel as energetic. And I have many of my patients who lost 10 pounds, and they said, I'm feeling much better. I thought it was old age creeping up, but it turned out to be the pounds. So this is summarizing that discussion. Okay, so what are then the renal effects of obesity? Well, I already alluded to, it's aldosterone, it's the renin-angiotensin system. But, when you have a big abdomen, there's actually some physical compression of the kidneys. And if you compress the kidneys, the blood vessels which have to go in, arteries and veins and sympathetic systems, and you compressing those physically, you have an increased abdominal pressure of over 40 millimeters has been measured in obesity. So there is a physical component. And then because you're overweight, your glomeruli have to work harder, so they get bigger. It's just like, you're lifting weights and your muscles get bigger. So the glomeruli become greater, so we call that glomerulopathy. And in addition, that for each BMI above 25, your eGFR initially goes up by 2.5 ml. So you may have an eGFR of 120, 125 initially, and then as your body readapts, it comes down. But there is a functional increase, at least for the first several years with obesity. So switching gear and said, okay, you already got CKD, my eGFR is 50, or my albuminuria is 100. So what are additional predictors of this continuing? One, diabetes, the pressure above 140/80, albuminuria, not that much when you're in the 30, 40, 50 range, but I would say if you're 100, 150, or 200, the progression from albuminuria leading to faster loss of eGFR is rather great. And then, of course, we now say that the heart and the kidney are married to each other. If your cardiac output suffers or you have HFpEF, and you have a higher venous pressure on the other side with a higher central venous pressure, that there's back pressure on the kidney. So basically, it's very important that worsening renal function has implication for the heart and vice versa. So, and as outlined here clearly is also obesity. So the complications of CKD is not that hypertension causes CKD, but also, unfortunately, CKD is an accelerator of hypertension. Already alluded to the cardiovascular complications, and now you have other things coming into play, anemia, and if you have heart failure, the iron deficiency may be another major contributing and remediable component of treatment, and you have the salt and water retention and the acidosis, and I'm just going to cover some of them one more time. So basically, what we now have for the last 5 years, whether it's you, me, or anybody who has CKD or got diabetes or what have you, other disease, if their pressure is above 130/80, the guidelines show that you should be below 130/80. So that most societies finally agreed that this is the ideal blood pressure, okay, with hypertension. And you can use whatever drug you want to, a thiazide or calcium channel blocker, but if you're starting to have albuminuria, from a nephrology standpoint, we prefer ACEs and ARBs in max tolerated doses. And you don't have to get there in one day. If somebody's pressure is 120, but they have albuminuria, you can start with 10 of lisinopril for a month, and then go to 20, and then 30, and it may take you 3 months, but the body actually then will tolerate the higher doses much, much better. And again, for us in nephrology, the salt intake around 4 or 5 grams, and you divide this by 2.5. So I like to talk in salt because I'm not taking sodium in. So you divide this salt by 2.5, you get sodium, or you multiply the sodium by 2.5, you get salt. So we come out to the same numbers. So to me, staying below 2,000 from a nephrology standpoint and a hypertensive standpoint is good. We have data actually in hypertension. If you go down to, let's say, 1,000 milligrams, so you go down to very, very low sodium intake, you stimulate the renin-angiotensin system, and it's actually counterproductive. So basically, the middle of the road from that standpoint, as already covered nicely, is the case. And here comes the biggest news in nephrology last year, that we always thought that if you have hypertension and your eGFR goes down to 35, 30, you have to stop the thiazides. And now the only drugs which work for diuresis from a heart failure standpoint and from a hypertensive standpoint are the loop diuretics. Absolutely wrong. We forgot that chlorothalidone works all the way down to an eGFR of 15. And look what happens. We have known for many years that loop diuretics are rather poor in the hypertensives. So if you have somebody with an eGFR of 50 and you give him 20 of furosemide with his 12.5 or 25 of hydrochlorothiazide, the blood pressure is much better lowered by 2, 3, 4 millimeters from a thiazide versus a loop diuretic. Okay, so look at that patient group. These were classic studies by Agarwal, who is one of the top 5 nephrologists in the United States just by everybody's opinion. He's a leading author and published some 500 papers, and he does terrific scientific work. He took patients with eGFR 23, 140/90 blood pressure, albumin over 300, elevated NT-proBNP, and he just switched half of them from the furosemide. He switched them to chlorothalidone. The average dose was 25, and look what happened. So the blood pressure, which was uncontrolled, was suddenly controlled. Okay, so he didn't add a new drug; he just substituted chlorothalidone, and you got the albumin down another 50% because you lowered intraglomerular pressure, and the NT-proBNP went down a little bit. So basically, the bottom line is, if you treat heart failure or you treat patients with hypertension, you don't have to switch from a thiazide to a loop diuretic until your eGFR is below 15. And that's very clearly what the data now show. And this is actually in November of last year in the New England Journal. To me, that was one of the papers of the year from a nephrology standpoint, because that completely made me rethink the approach to use diuretics. Again, If your eGFR is less than 45, 1 out of 5 have anemia, and you need to do the whole thing. You need the iron study, B12, folic acid. So you need to evaluate the patient because they may be iron deficient, and it may not be just from a renal standpoint. So they become anemic. That makes it worse. And as alluded to, phosphate is bad for the endothelium. So most people with eGFRs below 30, their serum phosphate level goes up. And that leads to lower calcium levels, that leads to activation of parathyroid hormone, and hyperphosphatemia, as we now know for some time, it causes endothelial dysfunction, so it's contributing. So basically, you measure when the eGFR is less than 45, your calcium, your parathyroid hormone, the bicarbonate level and vitamin D levels, and you try to keep it as close as possible to normal. So that's just a quick look. And the lipids, I think I don't like this lipid recommendation from the Kidney Society. I think you stick with your cardiology rules. I think they're much, much better. So most of the complications from the CKD are not from non-traditional factors, but you need to cover your traditional factors. So let the cardiologist decide how he treats or she treats the LDL, and use your criteria for LDL. And to me, if you have CKD, I like the LDL to be below 50 or 55 if you like. So basically, these are the lipids. So how do we then slow disease? So basically, you get the pressure down to less than 130/80. Okay. So the first line of drug is ACE or ARB. And if you're a woman, I always start with ARB. And if you're Asian, whether you're Chinese or Polynesian or Korean or Indian, if you're Asian, you have a 50% chance of cough. So don't even bother with an ACE inhibitor. So you reduce the salt to less than 6 grams. You use max tolerated doses of ACE or ARB. And you try to achieve a 30% reduction of the albumin, urine albumin. So it was 600, you go to 300, to go down by 30%. Most of them, if you get the salt below 6 grams, and if you get the pressure below 130, and you get max doses of an ACE or ARB on board, you can see as much as 50% reduction of albuminuria. So 1,000 may become a 500. And then the next terrific drugs are the sodium glucose inhibitors. They lower the pressure by 5 to 6 millimeters. We still don't know how. I think some of this is diuresis and salluresis, losing sodium, but they also are clearly vasodilators. And you have then a slowdown of eGFR by 2 ml. So instead of using 5 ml or 4 ml, you lose 2 ml. And that is true not just for diabetics, that's true for every single CKD cause except polycystic kidney disease, because we haven't studied it. So right now, the SGLT2 inhibitors are indicated in nephrology for anybody with albuminuria with normal eGFR, or anybody with eGFR below 60 with albuminuria or without albuminuria. So bottom line is you have CKD. By whatever criteria you start the SGLT2 inhibitor on top of the ACE inhibitor and ARB, and you have a chance of 2 ml per year reduction. So if you still have residual loss, let's just say you're still losing 2 ml after an ACE, after an SGLT2 inhibitor, or you have significant residual albuminuria, and you want to go down even lower, now we use finerenone, the mineralocorticoid receptor agonist. At this point, it is only approved in diabetics. The studies on non-diabetics are ongoing, so they're probably about 2 years away. But this is what we now call a 3-pronged or 3-column approach. We're learning from the cardiologists who have four classes of drugs for their heart failure: the RNA, the beta blockers, the SGLT2 inhibitors, the MRA. And now in nephrology, we have the ACE or ARB, we got the SGLT2, and if needed for residual risk, we add the finerenone. So we're on triple therapy, so we're missing still one. So we're trying to catch up. Okay. And so just to give you an idea why I'm harping so much about albuminuria, because if I am capable of reducing albuminuria, okay, by 30%, I will reduce your risk to go on dialysis about 24%. Okay? Let me give you a wonderful example. Your eGFR is 45, and you're losing about 4 ml as a diabetic or non-diabetic of kidney function a year. Okay, so you had 45, you lose 4 ml. Now I'm giving you an SGLT2 inhibitor, so you go from 4 ml loss to 2 ml loss. If you use the math and calculate, I just saved you 15 years before you go on dialysis. 1-5. So instead of going on dialysis in 10 years, you go on dialysis in 25 years. Well, you maybe by that time cardiovascular disease may have caught up with you, as we discussed. But just to tell you how dramatic a 2 ml preservation. But the bad news is, I haven't said that I make people better. We have absolutely no drug in nephrology which makes you improve your CKD. Okay, so if I get down to the 1 ml loss, age-related, I'm in total remission, if you would be talking, but as an oncologist. Okay, so I thought because albuminuria is so important, I'll just give you the drugs which at least will lower your albuminuria by 30%. And it's the ACE inhibitor, the ARBs, in max tolerated doses. For the SGLT2 inhibitors, we just pick one dose. They do all about 30-35%. GLP-1 receptor agonists turn out to really improve your endothelial dysfunction. They're not great for heart failure, but they do reduce MIs and CVAs, so which is kind of interesting. And the SGLT2 inhibitors don't do much for MI and CVA, but they're great for heart failure, and they're great in nephrology. And then the MRAs, the finerenone in diabetes and spironolactone and planorenone reduce albuminuria at least 30-40%, and not approved. There's no drug, by the way, yet at this point by the FDA approved for albuminuria reduction per se. But now you got CKD diagnosis, so you can put the CKD down as a diagnosis, so you'd be covered, although you only have quotes-unquote albuminuria with an absolutely perfect eGFR. And here's a quick look about, I heard a couple times today, this dilemma of creatinine going up. Don't panic if your creatinine goes up by 0.2 and 0.3, particularly if you have heart failure. This is not AKI, that's not kidney injury. It is actually just a hemodynamic event. And if you do sophisticated biomarker studies of the kidneys, and some even have biopsied, you cannot see any damage. Okay? So, what is now fascinating is that if you're not dehydrated, okay, when I give you an ACE inhibitor, and you're not lowering the blood pressure down from 140 down to 105. So you don't have excessive blood pressure control, and you don't have a dehydrated patient. But if you have an increase of creatinine, that's not talking about heart failure patient, per se, that appears to be a biomarker of poor cardiovascular outcomes in the future. We think it has to do with endothelial dysfunction. So an increase of creatinine actually, in the absence of volume depletion, the absence of hypotension, is a bad sign, and that one is now known for several years and has been also reproduced. Don't get tempted ever, unless you have hyperkalemia and need to stop a RAS blockade, because if you stop RAS blockade in a patient who has CKD and albuminuria for 5 years, like the US veterans did, they had 74% mortality, and they had still 60% ending up on dialysis. So you're not preserving renal function as well, and you're increasing your cardiovascular risk. The other group here was over 200,000 patients. I did this on purpose. I wanted to look into some heart failure data because these are cardiologists, and they stopped the RAS blockade because the potassium went above 5.5. And what happened? In the following 3 years, their mortality doubled. So now you got these potassium binding components outside of ketoxylate. You know, you got zirconium, and you got the sodium, calcium, and magnesium exchangers. So basically, what I'm telling you is, if you have hyperkalemia, you can stop it temporarily, but you need to restart it. So discontinuation of RAS blockade for whatever reason, there's a third article, even if your eGFR is less than 30, is a bad idea. You don't do the patient any favor from the standpoint of mortality, from the standpoint of events, and from the standpoint of delaying potentially them going on dialysis. So just a quick couple words be careful with NSAIDs. I know for every decade one gets older, one uses more for all these aches and pains one has. But basically, after 2-3 days, anybody becomes very salt sensitive, and they're knocking out prostaglandins. Therefore, your blood pressure pills, except for calcium channel blockers, become less effective. So if somebody has osteoarthritis and they need to take almost daily a form of NSAIDs, and they have, let's say, 140 systolic blood pressure, the drug of choice for that person would be a calcium channel blocker, because they're unaffected by being attenuated by the NSAIDs. And I think that people don't realize that if your eGFR is below 45 and your potassium is above 4.5, we call this the 4.5 rule, that puts you at the risk of hyperkalemia when you start a spironolactone type drug and also using NSAIDs. So remember that case above 4.5 and eGFR is below 45, that takes a little extra cautionary approach to drugs which potentially raise your potassium. So that's easily said, and I think, you look at the drugs which are renal excreted. Metformin needs to be stopped if you're less than 30, and then I already give you the rule of the 45s here. Okay, imaging, you got the image, use the smallest dose, and importantly is the hydration before, during, and afterwards. So don't stop for 2 hours or 3 hours afterwards. And if you really want to see whether you had a damage done, the time to wait for is 48 hours. I don't think there's much if by doing each of our creatinine the next day. So basically, if you're worried about AKI from diet, which can occur, usually it shows up very well by day 2. And referral, if your albumin is over 300, you got to do a urine protein, a serum protein electrophoresis. I used to find 3 or 4 myelomas a year, or 1 or 2 amyloids, some light chain disease, so plasma cell dyscrasia. So one needs to look at what you're excreting, what immunoglobulins or what light chains, which, by the way, light chains do not show up on a dipstick or urine albumin screen. So you got to really check by urine protein electrophoresis if you have red cell cast. And because we have a lack of nephrologists, I like to see the patient if they're less than 45. But for most part, that's impractical. So most really you need to wait till the eGFR is less than 30. So this is a recent guidelines which pretty much tells you, if you like algorithms, check albumin and check eGFR both in order to evaluate the patient. Then you have to put the risk assessment, what's the LDL, what's their blood pressure, and you go through all the things you can improve, what's the A1C with diabetes, and then you have the goal, blood pressure control, glucose, lipid control, lifestyle changes you heard so much about today, and then you have all the options of SGLT2 inhibitors, ACE inhibitors, and the residual risk, the use of finerenone. So the last slide is just the summary of trying to modify and reduce the loss of eGFR by as much as you can. Okay, so sorry about this big details, but I thought I'll give you about the more information I give you, the more sticks. So hopefully that changed your view on albumin and eGFR, that you need to do both and the importance of both. Thank you very much.